Hey, we're back. Back in action. Okay, cool. So first of all, I just want to review, and I hope you guys are good to go on this review here. But I want to review respiratory distress, airway compromise, and just some of the principles of airway management. So first of all, let's just make sure we're okay on our terminology. When we talk about respiratory distress, what does that mean? What's that? You're having difficulty breathing, right? So you have respiratory distress, okay? And these are things that indicate difficulty breathing, okay? So we'll just go distress. What is respiratory failure, however? What's that? That's a respiratory arrest, is... There we go, yeah. So it is inadequate. So you can have respiratory distress, okay? You can have dyspnea, nasal flaring, what have you, but still be able to ventilate and oxygenate effectively. Does that make sense? Okay. So you can be in distress, but not necessarily be in failure, okay? So distress may indicate there's failure going on, but those two concepts don't necessarily occur together. So failure is an actual failure of the respiratory system to either ventilate, oxygenate, or a combination of ventilatory failure and oxygenation failure. You guys okay with that? So if you find somebody, let's say they've overdosed on Oxycontin, and they're apneic, they're blue, their SATs are very low, and you start bagging them and find out their CO2 is very high, what kind of respiratory failure are they in? And yeah, they're both, right? Right? Does that make sense? Right, because how do we measure somebody's ability to ventilate? Yeah, CO2, right? Their ability to manage CO2. And then oxygenation is, yeah, it's PO2. Okay. Does that make sense? All right. Okay, because you can have somebody, let's say somebody has a large pulmonary embolism, for example, right? And their SATs are very low. They're becoming very hypoxic and hypoxemic, but they're ventilating just fine. They're getting CO2, inhaled exhale, just fine. That's somebody who has failure to oxygenate, but they're ventilating just fine. So many of these disorders can present as ventilatory failure, oxygenation failure, or sometimes a combination thereof. Okay. You guys okay with that? Okie dokie. So let's just review some of the major signs and symptoms of distress, okay, that perhaps points toward failure, but not necessarily. So nasal flaring. What is nasal flaring? Why? Why would we see that? Loud, right? Facilitates movement of air. We see this more pronounced in children, right? It's much more pronounced in children. Intercostal retractions. Why can we get retractions? What's that an indication of? Good. So accessory muscle use, right? The internal and external intercostal muscles are working, and they're an accessory to what's your main muscle of breathing, your diaphragm. Cool. Tracheal tugging and shifting. Have you ever heard of this before? Okay, so you can get you might get some deviation, or it gets pulled a little bit. And what kinds of things can tug or shift the trachea? Okay, so I'm not going to give you guys that. That's an elephant in the room, right? A massive tension pneumothorax. Okay, I already pointed the elephant. I want to know some other things. What are some other causes of tracheal tugging or shifting?
Pressure in the thoracic cavity, like maybe a fluid buildup.
Okay. Potentially, you're on the right, kind of on the right track. Okay, so consolidations in fluid buildup, right? And what is that going to do to the trachea? If you have a large consolidation of some sort of fluid or some sort of matter inside of the lung, and it's
going to increase resistance.
what's it going to do to the trachea, though? Huh? What way is the trachea going to move, though? The opposite? Is it going to move the opposite? Yeah, so is it the opposite, or
It's going to be the same density.
what do you mean, the same?
Like towards
There you go. Okay, this is an important point, guys, because probably up to this point you've just been told tracheal shifting is a tension pneumothorax and move on, right? If you have a large consolidation in the lung, it's going to pull the lung down, right? And it's going to pull the trachea, potentially pull or tug the trachea toward the problem, right? Does that make sense? Whereas if you have a large, say, tension pneumothorax, that air is going to push away from the problem. So does that make sense? Where you get pushing away from the problem and pulling toward the problem, and it depends on what the problem is. Is it a large collection of air, or is it some sort of what we call mass effect, something that is occupying mass in the lung, like a fluid or something like that? That makes sense? Okay, so you can't just look at the trachea and, oh, it's not midline, so it must be a tension pneumo. Not necessarily. There are other things that you want to consider. And is it being pulled toward toward a problem, or is it being pushed away from a problem? And what kinds of things do we need to do to assess? Lung sounds, right? Listen to lung sounds. What about percussion? There we go, right? A dull percussive note, a dull thudding noise over the area where there's a consolidation, right? That tells us there's something consolidating in there, right? If it is hyperresonant, you do your percussion and it kind of sounds like a echoing drum-like noise. That tells you that there's probably too much air in that particular area, right? And then we call that hyperresonance, right? You guys remember that from your earlier. Okay, cool. What's cyanosis? Kind of a bluish. Okay. What general types of cyanosis do we have? There are two general types of cyanosis, yeah. It has to do with the location. We have peripheral and central, right? Peripheral cyanosis may not necessarily be a respiratory or pulmonary issue, right? Other things can cause it. This is sometimes known as acrocyanosis when we're dealing with newborns and infants. But peripheral cyanosis may be the result of shunting, right? Maybe you're hypothermic, or you're in hypovolemic shock and you're shunting blood away from your extremities. It might be the result of an injury or some sort of vascular problem, an arterial occlusion, for example, something we talked about in cardiology. Okay, central cyanosis does generally point more towards some sort of pulmonary issue. Okay, what's pursed lips? Yeah, so you're blowing through duck lips, right? You're taking a selfie, right? Why? What does that do? It provides what? PEEP. That's exactly what pursed lip breathing is it is applying PEEP. Cool. Yeah, it splints the alveoli, provides some pressure at the end of exhalation. Good. Accessory muscle use. Okay, so intercostals, you can have your sternocleidomastoid, right? substernal as well, diaphragmatic, abdominal muscles as well. So you have lots of different accessory muscles there. Irregular respiratory patterns, right? Shallow, irregular, something like agonal respirations, biots, chain stokes, okay? Inadequate rate and depth. So when would we, what rate and what depth, when would we take over breathing? When would we institute positive pressure ventilation on somebody?
When they're failing to ventilate or oxygen.
Yeah. So it's not necessary, there's no hard line that we can draw, right? I can't tell you if it's greater than 24, you just need to bag them. There is no hard line in the sand that you draw. You have to base your decision on all the available information, right? I could be breathing 30 times a minute, right, when I'm out running. And does that necessarily mean that you need to cram a nasal airway into me and start bagging? Not necessarily, right? But if I'm unresponsive and my mouth is full of secretions and I'm breathing 30 times a minute, it's shallow, well, in that case, you might need to open my airway, suction, insert an adjunct, and bag. So it's really going to depend on the whole assessment. Cool. Abnormal positions. What are some abnormal positions you could think of? Tripoding would be a classic. Yeah, a classic indication. Good. Pursed lip. Hey, look at it, covered again. Some other things. Your end-tidal CO2, right? Specifically the capnograph, the waveform, right? What does the waveform indicate?
Inhalation and exhalation.
Exhalation primarily, right, in the waveform. And the morphology of that can change, right? For example, you get that shark fin pattern that indicates delayed emptying of the alveoli, right? Which is obstructive pathology, right? Mucus plugs, secretions in the tube, bronchospasm, those kinds of things. Good. A decreased pulse oximetry reading. Anxiety and altered level of consciousness. Anybody with respiratory signs and symptoms that presents with altered mental status, you need to assume that they are hypoxic until proven otherwise. Okay? Now, it could be some other problem going on, but if there's respiratory distress and altered mental status, you need to assume that that is due to some hypoxia. Wheezing, what does wheezing indicate? Okay, bronchospasm, constriction, good. Or if it's unilateral, it may indicate a foreign body, right? Good. What about crackles? Fluids, okay. And some people can divide that into like rhonchi, which is, kind of a rattly, fluidy sound, but I just tend to go with crackles because it's simpler. All right. And then just what your patient complains of, right? Do they complain of dyspnea? Is it tight to breathe? Is it hard to breathe? What does it feel like? So lots of different things there. Okay, cool. So that's respiratory, but we also need to identify airway compromise, right? So what is snoring indicative of? Yeah, and what is the most common cause of airway obstruction in an altered patient? The tongue, believe it or not, right? The tongue. All right, good. You guys okay with that? All right. What's stridor? That is almost always upper airway, right? It could be a foreign body. It could be edema as well. So things like epiglottitis, tracheolaryngeal bronchitis, also known as tracheolaryngeal bronchitis, also known as croup, right? Croup, yeah. Or somebody who's been extubated, right? We extubated them. We discontinued the endotracheal tube. Maybe they had some irritation, got some stridor there. Maybe they have some sort of burn, right? Some sort of airway burn. Okay. Again, what does unilateral wheezing indicate? potential foreign body, right? Secretion management, right? Can they manage or maintain their own secretions, i.e. can they swallow? Crackles slash rhonchi, okay? We have some sort of fluid buildup. And edema is a big one too, particularly if you look at the neck or the face. And is there some sort of mass effect? And what do I mean by that is there like a hematoma maybe they have an injury and they have a rapidly expanding hematoma that's developing. Maybe they have a tumor as well, or neoplasm. What is angioedema? Yeah, that's a swelling of the mucous membranes of the airway. What kinds of things cause angioedema? Anaphylaxis is the big one, right? Anaphylaxis. There is another cause that is not at all related to allergies, though, and that is a medication. You guys should know this. Say it again. And what class does that belong to? No. What is that? It's not a beta blocker. ACE inhibitors, right, guys? Angiotensin converting enzyme inhibitors, okay, are known to cause life-threatening angioedema. And remember that angioedema is not mediated through the same immune pathways as anaphylaxis. So you can give all the epi in the world to somebody with ACE inhibitor induced angioedema and they will not improve. Right? So it's a much different situation than anaphylaxis. Okay, what's trismus? Spasm of the masseter muscle, right? Good. What can cause trismus? Trauma where? The head and face, right? Lefort fractures particularly, right? And we haven't talked about that yet because we're not in trauma, but yeah. Some other things, certain diseases like tetanus. Yeah, tetanus. Yeah. And then just trauma in general can compromise the airway. Okay, cool. You guys good with that? Just review, I hope. All right. So just some general principles of airway management. You guys should know this stuff. So first and foremost, positioning that airway, protecting it, and suctioning it, right? That's one of the first things that we do when we suspect airway compromise, right? We open it, we position it, we protect it, and we suction it if needed, right? And sometimes we might need a suction before we bag, right? If somebody has an airway full of junk, you may need to suction it and then begin bagging, right? Clear the airway and then begin breathing. Okay, supplemental oxygen, right? Give them oxygen if they have respiratory distress, complaints of dyspnea, or you suspect hypoxia. And then I just want to emphasize this, never withhold oxygen if indicated. If you think it's indicated, give it. We can figure out later how to titrate it down, up and down and all that. Now, there is this concept known as the hypoxic drive. You guys ever heard of that? What is the hypoxic drive?
When your body has been so accustomed to kind of low pH from the CO2 buildup that it switches over to the oxygen, low oxygen.
Okay, that is the classic story that we hear. The classic story that we hear is somebody has some chronic lung disease, right? And what happens with that chronic lung disease is their CO2 becomes chronically elevated, right? Which does what to their pH? Lowers their pH, and their body becomes accustomed to that low pH, right? And so their normal mechanism for breathing, which is a pH-based mechanism, becomes altered. And their primary, instead of a pH mechanism, their primary drive is an oxygen mechanism, right? And so it is low oxygen levels that triggers breathing as opposed to high acid levels. You guys cool with that? Is that pretty much how you guys understand that concept? Let me ask you a question though. What does a typical blood gas look like for someone with chronic lung disease, with COPD? What does their blood gas show? Compensated respiratory acidosis, which means their pH is what? It's in the normal range. Their CO2 is elevated, yes, but their kidneys are making and holding on to more bicarbonate ions and compensating for that. So what's their pH? It's normal. It's in the normal range, right? That kind of blows that whole hypoxic drive thing out of the water, doesn't it? If you think about it. If that's the rationale we're going to use for the hypoxic drive. But when we look at somebody with this chronic lung diseases, they're often not, their pH is often normal, right? And remember we said if their pH is abnormal, that indicates an acute problem, doesn't it?
Does it have to do with the centers of the brain and they tell the body to breathe? The CO2 is constantly sending breathe, and fast. So that's why it switches over?
No, because the acid is normal, right? The pH is in the normal range. The body compensates for that. And the only time the pH is abnormal in someone with chronic lung disease is when they have an acute problem. So guess what? This hypoxic drive thing that you guys have probably heard about this many times, right? It's kind of a myth. It's a scarecrow. It's one of those great things that we teach everybody, that everybody's taught. And there isn't a whole lot of evidence to back it up. It does exist to some extent, but it doesn't appear to play as major a role as we think. And so the answer is, okay, the answer to the question is, why do you suppose really sick lung disease patients who get oxygen, why do you suppose some of them quit breathing? Is it due to the hypoxic drive, or could you think of another reason why they would maybe get worse? It's a real simple answer. You're on the right track. They just get sicker, right? They're getting sicker. I mean, it's that simple. Yeah, they're just sick. They're really sick patients. Does that kind of make sense? So the hypoxic drive is not really as big of an issue as people have really made it out to be. It does exist to some extent, but it doesn't play nearly the role that we thought. There are some things that we found that sometimes oxygen, when you give somebody large amounts of oxygen, it can alter their pulmonary circulation, and it can cause vasoconstriction within their pulmonary circulation, and that may actually exacerbate the what's going on. Something known as hypoxic pulmonary vasoconstriction. But as far as a hypoxic drive goes, the evidence doesn't support it as a real robust concern. Okay, now you guys are probably still going to be yelled at by Nurse Ratchet at the hospital. Why did you give him oxygen? He can't quit breathing. Okay, if your patient quits breathing because you give him some supplemental oxygen, okay, there's probably other concerns to worry about. So you guys okay with that? Okay, I know, sorry to pop that balloon or burst that bubble, but there you go, yeah. So the hypoxic drive is not nearly the issue that we thought it was. Now there are definitely issues with giving oxygen, right? Oxygen toxicity is a real issue. This abnormal vascular response in the pulmonary circulation might be an issue. So it's not completely benign by any means, but at the end of the day, if we think patients need it, we give it, and we just deal with them as needed. You guys okay with that? Oh, it still goes on, yeah. Nothing, it's just, it's like Reiki healing. It's like Reiki healing, you know, people like, oh, I'm gonna align your chakra energy points and you'll feel better, you know, it's just Reiki, yeah. It kind of falls into that, kind of into that new age kind of stuff. Well, yeah, because some of what they would do is they would add they'd add oils and things like that to flavor to make the oxygen smell. You know, oh, here's banana and strawberry, and people would inhale, you know, like petroleum based stuff and develop pneumonitis and things like that. Yeah. But yeah, there's no evidence that, you know, oxygen bars help people. It kind of falls into that, you know, all that, like, you know, the Reiki healing, and there's just no evidence that supports it. But, yeah. Okay, you guys good there? Okay, let's move right. Okay, so what I want to do now is I want to talk about pneumonia, and this kind of comes out of your book. Pneumonia is toward the beginning of your chapter. So first of all, what is pneumonia? Let's kind of just. Okay, but that's kind of a broad. When I say an infection of the lungs, I mean that's like. Okay, but can we kind of narrow it down a little bit? Really, what are we talking about? It is an infection, yes. It is an infection. There we go. It involves consolidation within the alveoli, okay? So within the alveoli, that's where the problem is, within the parenchyma of the lung. Okay, you can get a virus, it could be viral, it can be bacterial, it can even be fungal in some cases. Okay? And these organisms take up residence, right? They begin to multiply, and then they trigger a whole cascade of problems. Inflammation occurs. What happens with inflammation? That draws the immune system in, right? You get white blood cells infiltrating the area. You get fluid shifting in the area, and the alveoli begin to fill up with stuff. And that's what we call a consolidation. Right? You guys okay with that? All right. That's fundamentally what pneumonia is. So it's a problem with the alveoli. And there are some general types that you want to be aware of. There's what we call community-acquired pneumonia, or CAP. And this is the run-of-the-mill pneumonia that you get where? Community-acquired pneumonia. Where do we get that? Yeah, in your community, right? Outside of the hospital, right? In the community, right? So these are your run-of-the-mill organisms. You also have healthcare-acquired pneumonias. One of the most problematic ones that we run into is VAP. And what is VAP? It's a big problem in the healthcare world. Well, what does it mean, though? Ventilator-acquired pneumonia. So this is patients who are intubated. And then, of course, aspiration pneumonia as well. And remember, we talked about this briefly already. Certain things can increase your risk of aspiration pneumonia. Stroke, for example, is a big one, right? You guys okay with that? Now, healthcare-acquired pneumonias, do they tend to be more or less problematic in some sense? Why? Higher rates of antimicrobial resistance. Absolutely, right? If you get a pneumonia after you're admitted to the hospital, that pneumonia may be a lot worse because those bacteria may very well be highly resistant to many of the frontline antibiotics. Okay, hard to treat.
Would it be the same if, like, you went to the hospital and you got the VAC, is what you called it?
Mm-hmm.
Specifically from a ventilator? Would that be the same as if you went to the hospital and you started aspirating and you got pneumonia in the because of that, but it still be just as dangerous because of
Well, aspiration pneumonia can be pretty terrible regardless. Yeah, if you aspirate in the hospital, it's still an aspiration pneumonia.
so
Yeah.
would that technically be considered the healthcare required because
Well, it would be because yeah, or you can aspirate. You can aspirate at home too, right?
well, yeah.
Yeah. So aspiration pneumonia may be healthcare acquired, or it may be you went out on a drunk bender and aspirated. But yeah, if you acquired it in the healthcare setting, there's going to be some concerns, some additional concerns for sure. Yeah, absolutely. Yeah. So we used to say that when we intubated somebody, intubation prevents aspiration, right? So you put an endotracheal tube in the trachea and you inflate the balloon. Well, that prevents stuff from getting into the trachea, right? Protects from aspiration. No, actually it doesn't. We find out that microaspiration is a very common thing. So guess what? When you guys are going to be dealing with patients on ventilators, a couple to a few times a day, what do you think they end up doing to those patients? Obviously suctioning their mouth out, but they do full-on oral care. They brush their teeth, rinse and wash the mouth out. Why? To try to cut down on VAP rates. Cool. Okay, so and there's another type of pneumonia called atypical. I'll just throw in that. Atypical pneumonia. Some people call this walking pneumonia. Okay. And this tends to have kind of a more slower, kind of an insidious onset. And good Lord, my wife is going crazy today. She must be back from Afghanistan. Yeah, atypical. This is tends to be the result of certain bacteria called mycoplasma. So some people call this like primary atypical mycoplasma bacteria or mycoplasmic pneumonia. Walking pneumonia is a more vernacular term. And so it can present kind of a slower, mild, more insidious onset and may not have some of the classic signs and symptoms of a pneumonia. Okay, but our history and physical exam, fever is a big one, right? Whenever we're trying to differentiate an infection from a non-infection, a fever is always a good thing to look at. However, some patients may not respond with a febrile response, particularly people who are immunocompromised, like elderly patients. They may actually be hypothermic. Okay? So you may check somebody's temperature, particularly if they're immunocompromised, and they may have a lower than normal temperature, and that may be an indication that they have an infection. Okay, so not only are we looking for fever, but we're just looking for alterations in temperature in general. Clearly coughing, right? That's one of those protective mechanisms. They're trying to clear their airway. What's myalgia? Well, algia is pain, and then myo is muscle, right? You guys have had that, right? You've had a cold, and what happens? You just hurt all over, right? You just hurt. You kind of have that sore, crawly feeling all over you. That's what we call myalgia. Common with viruses. Chills, right? Particularly when you get hyperthermic, you get the chills. You have your patients coughing up mucus that is green, black, or brown. May have a characteristic smell to it. You listen to their lungs. What are you going to hear? You're going to hear crackles. Typically, where does the pneumonia start? In the bases, right? It tends to start in the bases, lower lobes, and then work its way up. Good. Abdominal pain. This is kind of one of those weird signs, or symptoms rather. Particularly when it starts in the lower lobes, you can get some irritation, and that irritation and inflammation may present as abdominal pain. So somebody can have abdominal pain and a fever and not feel very well, And one of the things you should be thinking about, in addition to all the laundry list of abdominal complaints, is pneumonia. Does this patient potentially have pneumonia? Okay. What is malaise? Just tired, right? Tired. Yeah. Okay. And immunocompromised patients are going to be at higher risk for pneumonia, for sure. So cancers, if they've had a transplant, why? Why transplant patients higher risk? They're on immunosuppressant drugs. Good. And that's also why transplant patients are at much higher risk for developing cancer as well. HIV, extremes of age, if they've had trauma or surgery, right? If I've had a major trauma or major surgery, I'm going to be bedridden. I may not be able to take deep breaths. I may not be able to effectively clear the airway. I can get stuff building up in the airway and develop pneumonia as a result of that. Pneumonia is fairly common after rib fractures as well. So you're not breathing as deeply, and then you develop atelectasis, and then that can go on to developing pneumonia because you're not effectively clearing that area. Yes, we don't. So like with rib fractures, we don't wrap them and splint them and all that. It's just best to kind of deal with it. I know it stinks, but I've ended up breaking a couple of ribs in the past year due to crashing my bike, and it is awful. It's not very fun for sure. Okay, so how would we treat? So we assess them. We know a little bit about their history. How are we going to approach them? Well, supportive care, obviously, right? IV therapy. Do you think IV therapy is going to be important? Yes, right? If they have a fever, if they're breathing, if they're tachypnic, right? They're tired, they may not be eating or drinking, they very well may be dehydrated, right? So give them a fluid challenge, right? What if they have wet lung sounds? Are you concerned? Yeah. So remember, not all that crackles is a failing heart, right? So you need to be a good investigator and be able to separate out what's going on. You know, if they have a fever and they have chills and they're coughing and they have a history that points to pneumonia and they have these crackles, you got to go, okay, well, everything's pointing to pneumonia. They're tachycardic, they're febrile. I'm going to give them fluid, and I'm going to be justified in giving them fluid based on my assessment. Does that kind of make sense there? Cool. Oxygen as needed. Now, beta agonists, only if wheezing present. Okay? Does albuterol magically scrub your alveoli clean? No. Okay, it does not magically scrub your alveoli clean of consolidation. So albuterol is not going to help somebody with pneumonia unless they have associated bronchospasm. Does that make sense? So if we're going to give somebody a quote-unquote breathing treatment, we're going to give them a beta agonist, we need to be justified in doing that, right? And why do we give beta agonists? Bronchodilation, right? If there is no indication that they have bronchospasm, then beta agonists really aren't indicated. Now, if you do suspect bronchospasm, because guess what? Pneumonia can irritate the bronchioles, can cause spasm, by all means, give it, but just make sure that you're justified in giving it. You guys okay with that? Cool. In the hospital, we're going to get an x-ray of their chest, and we're going to do culture and sensitivity of their sputum. So we've got to figure out what the bug is, right? We've got to identify the bug, and then we've got to find out what kinds of antibiotics work. They're going to receive antibiotic therapy, and then some other things, mucus mobilization. Okay? These are techniques that we can do to help break stuff up and get stuff out of them. CPT, that stands for chest physio or chest physical therapy. Okay? Yeah, so we can do this in many ways. We can use little cups, we can pound on their chest. We can use little pneumatic thumpers that hooks into the high pressure oxygen. You turn it on and it goes like that, and it thumps their chest. Or some patients, particularly like cystic fibrosis patients, actually will put a vest on a whole body vest, and they'll turn the vest on. The vest will vibrate their entire thorax and break that mucus up. Okay, so these are therapies you may run into. Turn, cough, and deep breathe, right? This is something that sometimes we try to do, particularly with patients that are hospitalized, right? Turn them on their side. All right, cough, take some deep breaths, get them on their other side, right? Incentive spirometry, what is that? There you go. Yeah, so before you have your surgery, they should come in and do that with you to find out what your baseline is, right? And do you blow into it? With the incentive spirometer, you blow into it? Sure? There you go. You do not blow into them. You suck. It's incentive spirometry, so you are inhaling. You're not exhaling. Yeah, so an incentive spirometer is, right, a controlled, sustained, prolonged inhalation. And then you watch the little thing go up, right? And you try to get it as high as you can, and then hold it, let it out, and you do that half a dozen times every hour or so optimally, right? And we should be doing this with all of our surgical patients. Right? And what does that do? Well, that mobilizes their alveoli, opens them up, mobilizes secretions, and can help prevent atelectasis and pneumonia. You guys good with that? Cool.
Quick question, what was the CPT, what did it stand for?
Chest physical or physiotherapy? Yep. If your pneumonia patient is having a particularly hard time breathing, non-invasive ventilation may be helpful. CPAP or bilevel positive airway pressure. It can help with the respiratory distress, and it can actually decrease the need for intubation in certain patients. And at the end of the day, if we can prevent intubation, we want to, right? We do not want to intubate patients, because when we intubate them, then we set them up for a whole variety of problems. Hemodynamic compromise of their intracranial pressure, ventilator-acquired pneumonia, et cetera, et cetera. So, yeah. So if we can prevent intubation, definitely. So CPAP or non-invasive ventilation in general may help. And then if we have to, we might have to initiate airway management. You guys okay with that? Okay. Just a quick note about non-invasive ventilation. Remember, we have to have an awake patient, and they have to be oriented enough to cooperate, right? They need to have an intact and patent airway. They need to have hemodynamics that will tolerate non-invasive ventilation. If they have a blood pressure of 70 over 30, CPAP's probably going to be a very poor choice for them. At least until maybe you can give some fluids and, get their blood pressure up. Okay? You okay with that? All right. Pneumothorax. If you suspect a pneumothorax, non-invasive, any kind of positive pressure ventilation is going to be potentially harmful. Good. And remember, these are your major indications for non-invasive ventilation. Congestive heart failure exacerbation with pulmonary edema, pneumonia, and asthma and COPD exacerbations. Okay, all three conditions may potentially benefit from non-invasive ventilation, assuming they meet the criteria and there are no major contraindications. You guys good with that? All right. Moving right along. Let's talk about asthma. I know we talked about this yesterday, but let's just talk about it in a little more detail. So what kind of pathology is asthma in general? It is obstructive. It is an obstructive lung disease. It's due to hyper-responsive airways, right? And these airways are hyper-responsive to some sort of trigger. Okay. But what differentiates asthma from other chronic pulmonary diseases? Good. Reversibility, right? Reversibility. COPD is not reversible. Okay. It is commonly associated with allergies. And whenever a disease is associated with an allergic response, we call that atopic. So have you guys ever heard of the term atopic dermatitis? Right? That is a inflammation of your skin resulting from an allergic response. So atopic means an allergic response. So here are some major triggers. Cockroaches, right? Big one down here, particularly dead ones, right? Dust, exercise, pollen, stress, animal dander, household chemicals, and infections, right? If they develop an upper or lower respiratory infection, or what we call a URI, right? An upper respiratory infection. And possibly even very hot, very cold air, very dry, or very moist air. Okay, so there are a whole variety of triggers. So the typical presentation of somebody with asthma is they had some sort of trigger, and then they developed this obstructive pathology due to the hyper-responsive airways. So how do these patients present? Signs and symptoms? Wheezing's very common, right? Okay. And so some of the history, do they have an asthma action plan? And do they have a peak flow meter or peak expiratory flow meter, right? If they do, have they measured it? And what three color zones do we have? Red, green, and yellow, right? And where are they at? Okay, did they treat themselves? And what was their response to their treatment? Okay. So with the respiratory distress, initially what we see in somebody who has a quote-unquote asthma attack is a respiratory alkalosis. That's the initial finding. Why? Because they start breathing faster and deeper. So initially, you're not going to see the classic CO2 increase and the SpO2 decrease and all that, okay? If you were to look at their ABG early into the attack, you'd be like, oh, this is somebody who does not have a respiratory problem. They have a respiratory alkalosis, right? Don't let that fool you, though, because that can deteriorate to respiratory acidosis with hypoxemia or hypoxia. And let me just ask a question. What is the difference between hypoxemia and hypoxia? Good. So it is low oxygen in the blood, whereas hypoxia is good. It is a tissue problem. Yeah. The tissues are not receiving. In some cases, you can have a low saturation. You know, you could be saturating, say, 88%, which a lot of chronic lung disease patients do, but their tissues may be getting adequate amounts of oxygen. Or you can have both occur at the same time. Okay, so how do we treat asthma? Well, let's start with mild to moderate signs and symptoms. Okay? Right? ABCs. You guys good with that? ABC, supportive care. Should they be on the monitor? Yeah, anybody with any respiratory complaint should be on the monitor. Okay, get their peak flow. Get them going on waveform capnography, right? We want to measure that. We want to look at their waveform. Give them oxygen if they need it. And what's our primary medication that we're going to use? We're going to rescue them, yeah. We're going to rescue them with a short-acting beta agonist, or a SABA. And what are the classic short-acting beta agonists that we give as rescue agents? Albuterol, good. And levalbuterol, or Zopanex. All right. Yeah, these are classic. Okay. Now, we might add an anticholinergic into that as well, right? That can help with some of the inflammation, some of the mucus production. What is the most common anticholinergic agent that we use? Ipratropium or Atrovent. Okay, and when we give that with albuterol, this is commonly called a Duoneb. I actually believe Duoneb is a trademark name. So it's actually not totally correct to use that, but that's kind of the vernacular term. Okay. What about fluids? Do you think patients with having asthma attack are probably going to need? Yes. Okay, they're often going to be a little hypovolemic. Give them some fluids. And then steroids. Okay, we have inhaled steroids like Pulmicort or budesonide. Okay, would you give the steroid? Would you give that first? No, you give your rescue agent first, right? You rescue them first, then you give your steroid. So you have inhaled or you have systemic. And you have two flavors of systemic steroids. You have oral, right? And then you have your parenteral, which is typically IV, sometimes IM. What is the common parenteral steroid that we administer? Solumedrol or methylprednisolone, right? Generally at a dose of about 1 milligram per kilogram. Or what some people will do is just give an adult patient 125 milligrams solumedrol. Hydrocortisone or solucortef might be used, which is generally 100 milligrams in an adult patient. There are oral steroids as well, right? Prednisone, prednisolone may be given orally. Are steroids for acute management, though? No, they're for chronic management. And remember in pathophysiology how we talked about the early and late phase response? In the early phase response, you have mast cell degranulation that causes a histamine release, and that triggers the initial asthma attack. And you can treat that, right? But then what can happen over several hours? What's that? Why though? What happens over several hours? No, they don't have. No, there's a specific process that happens that. You guys remember this? Talking about this, the late phase response. So there is a substance within the cell wall of those mast cells that degranulate. They basically blow up, right? And that's known as arachidonic acid, right? And that arachidonic acid is metabolized because it's released from those cells. And there are two pathways that it gets metabolized to, right? It gets metabolized through the lipooxygenase pathway and the cyclooxygenase pathway. These are enzymes. It is metabolized through the cyclooxygenase pathway into prostaglandins. And remember, prostaglandins are a class of pro-inflammatory mediators that cause inflammation, right? And the lipooxygenase pathway metabolizes the arachidonic acid into leukotrienes, which are also pro-inflammatory molecules, right? So what happens is, following the initial asthma attack or COPD exacerbation, if that's the case, several hours after that, they can develop another attack that can be prolonged and difficult to treat due to the arachidonic metabolism and other processes occurring. And this is why we will sometimes give steroids to these patients to attenuate or to block that late phase response, right, to prevent them from having problems after they feel better and they sign, a waiver saying, well, I don't want to go to the hospital, right? So this is a point of education for your patients too, right? Now, let's say your patient feels better, you give them some albuterol and they feel better on scene. You need to talk to them, you need to explain to them. You probably don't want to use arachidonic acid terms, but you need to be able to distill that into, hey, there are some substances that might be released that can cause problems later on, and we really should take you to the hospital and get you checked out, and they may want to get you on some other medicines to prevent these problems from occurring. So you guys okay with that? Does that make sense? Okay, cool. All right. Now, some patients will take what are known as LABAs. And what is a LABA or a LABA?
Is it a inhaled steroid?
Well, what's a SABA?
This is a long
Yeah, so SABA is a short-acting beta agonist like albuterol. So ALABA is a long-acting beta agonist, something like salmeterol or metoprolol, something like that. Okay. Do these have a role in rescuing patients? No, absolutely not. Long-acting beta agonists are for preventive or what we call maintenance therapy. These prevent asthma attacks from occurring, but they don't have a role in rescuing patients. You guys okay with that? Some other preventative or maintenance drugs that you run into, leukotriene inhibitors like Advair, inhaled steroids, okay? And in fact, I have a combination of a long-acting beta agonist steroid, and this is something called Advair, okay? And this is known as a DPI, a dry powder inhaler. And I'll show you guys this in lab, okay? Some patients may have a metered dose inhaler, an MDI, right? And can we use MDI to treat somebody having an asthma attack? What do you think? Sure, as long as it is a SABA, a rescue drug, right? Because guess what? Some MDIs may contain steroids, or they may contain a combined LABA and a steroid or a long-acting beta agonist. So you got to make sure if you're going to use an MDI that the MDI, okay, this is salbutamol or salbutamol, which is another term for albuterol in other countries. I actually got this from Mexico, so Mexico and Canada, right? The names are a little different, generic names are a little different. So salbutamol is albuterol. Paracetamol is Tylenol in those countries as well. So the names can be a little different. Okay. So what do you think as far as using an MDI? So an MDI versus a low volume or small volume nebulizer. Okay, that's the little handheld nebulizer. Which one do you think's better, this or the handheld nebulizer, a low volume nebulizer? Guess what? They're the same. All the evidence points to the efficacy being the same, right? Yeah, kind of a mind blower, huh? We like to think that it's better with that. Not really. Most of that medicine that you give via a handheld nebulizer or a low volume neb, 90% of it just splatters on the inside of your airways, right? You have 10% or less of that actually makes it into your alveoli. Yeah. So, and we'll simulate using this in lab because I think you guys need to get your MDIs and your med stuff check-offs anyway. So I told you I'd bring it, and so I did. So how do we take it? If we're going to give somebody an MDI, what is the technique?
The 6 rights first.
What's that? Yeah, do your rights and all that. But
So you should make sure you shake it up.
okay, so make sure you shake it. Okay. Okay. So you want to seal your lips around this, right?
Yes.
Make a good seal, right? Because you want all that medicine when you get that great seal with your lips, and you hit that, and it's going to inject that medication all over the back of your palate, huh? Oh no! You guys have been taught the wrong way to do it, haven't you? You do not make a seal with your lips around this. This should be a couple inches away from your mouth, right? Do not let your patient seal their lips around it. This needs to be like 2 inches away from the mouth, and then have the patient begin to inhale, and as they're inhaling, then you go shh, shh, because you are mixing the albuterol up in the inhaled air, right? And once it gets mixed, there's a greater chance for it to impact in the lower airways where it needs to go. If you make a seal with your lips around it and you hit it, you hit it, where's it going to go? All over the back of your mouth and throat, right? That's not where you want it to go, right? You want inertial impaction in your lower airways, in your bronchioles. Does that make sense? All right, so if you're going to use it that way, you need to get it out of the mouth, and you need to get it about an inch or two away from the mouth. Have them inhale. If you can get them to hold, to do an inspiratory pause, that's even better, right? And then exhale slowly. That is the optimal technique. You might need to modify it depending on the degree of distress they're in, right? The best technique is to use what's known as a spacer, right? Now, this is just some corrugated tubing. Okay, there are real fancy chambers and things like that, but this works just fine, right? You stick that in there, cover the end, and then what do? Right? Do your 1 to 2 puffs, okay, and the puffs fill this up, and then you can have the patient inhale it at their leisure, right? And you can get that seal that they want and all that. And a spacer can actually be very helpful at. Well, it is. It's going to get over there, but what's going to happen is they're going to inhale, and then it's all going to get inhaled in, right? Unless like it's all wet inside, because it's a particle, right? It's a particulate. It's a fine particle. It's not wet. The stuff in here is not wet. It's dust. It's like big, really fine, dusty particles. So they're just going to float around. And as long as it's dry inside of here, yeah, some may stick, but then when you inhale, all that'll go in. But it's not like squirting it all over the back of your wet throat where it just sticks there and then doesn't go anywhere. Does that make sense? Okay, so using a spacer, you can even use like a toilet roll or a roll from a paper towel roll as a spacer. There are many things that you could improvise for spacer. You guys okay with that? So I bet you all were taught to do the whole lip thing, huh? Yeah. And that's why, in some cases, people don't think MDIs are good. Because nobody uses good technique. Right? But if you use good technique, the efficacy is about the same as using a handheld or a low volume nebulizer. You guys cool with that? Learning new stuff. Okay. Let's talk about status asthmaticus. What is status asthmaticus? What's status asthmaticus? Yeah, so it is a sustained severe asthma attack that does not respond to rescue therapy. Okay? So this is a critical emergency. This is a critically ill patient. So what do we need to do? Obviously treat and assess the ABCs. If we have to take over their airway with a BVM, can we try to bag a neb in? Yes. Do you guys know how to do that? Do you know how to bag a neb in? No. We'll cover that in lab. Yeah, we'll cover that in lab then. I'll show you how you can do that. Bag a neb in. Yeah. With a BVM. Yeah. It's okay. You can feel free to move. You can move closer if you want. If you're having a hard time hearing. Okay. CPAP or BiPAP, right? That may help. May help their breathing, and it may help facilitate better delivery of medications. Continue rescue drugs. In some cases, we may need to give a continuous albuterol treatment, like 5 to 20 milligrams of albuterol over an hour. We call that a large volume nebulizer. We may need to give them epinephrine as well, right? Treat this like anaphylaxis. 0.3 milligrams IM, an adult patient. Magnesium sulfate may have a role. It may help. Okay, it's not a primary agent, but it may help. 1 to 2 grams, slow IV over 10 to 15 minutes. And if we have to intubate them, do we need to alter the way that we ventilate them? What do we need to ensure happens? A prolonged expiratory phase. We need to allow for lots of time to exhale, okay? Because if we don't, we may end up air stacking and auto-peeping them, and they're probably auto-peeping themselves to begin with, all right? In some cases, we may even need to take the bag away and push on their chest to get it to deflate a little bit, okay? So you need a prolonged, you may only give them like 6 breaths a minute, right? Allowing for prolonged expiratory phase. And you're gonna watch their heart rate, watch their blood pressure. Their heart rate goes up, their blood pressure goes down while you're bagging them. You're probably gonna need to give much more time to exhale. Because this truly is a ventilatory problem, right? That's your primary concern, is that ventilation, and you're not getting that air out of them. You guys okay with that? You're going to need to closely monitor them. You're going to need to reassess them. Heliox may have a role. We've talked about Heliox already, but it's not something that we have readily available in the field. You guys okay with that? That sort of kind of makes sense? All right. All right, very good. Let's